Good day. I'm Dr. Matty. I want to talk about how to deal with a retained catheter. There are a few times when a patient comes to the clinic for routine catheter change, or the doctor is called to deal with a retained catheter for a patient that is due for catheter removal. For instance, catheter was passed for surgery, and now a service purpose, we have to remove the catheter and discharge the patient. Or for some reason, we are struggling in removing the catheter. So the nurse or the attending physician usually will attempt to connect a syringe to the valve and try to withdraw the instilled saline to deflate the balloon. But this won't work after repeated attempts. It does so happen that sometimes, maybe due to inferior product design or error in production at the factory level, some of the valves of the balloon are faulty. This is very common with the latex type of catheters. For the silicone catheters, usually it doesn't give that problem. But in case you have that challenge, what do you do? What you shouldn't do, which most desperate clinicians might attempt to do, is to cut the valve. So they cut the valve with the hope that the normal saline instilled to inflate the balloon will then leak out after they have cut the valve. Most often than not, it doesn't work. What you shouldn't do is to forcefully pull the catheter out, because catheter that has been passed through the urethra into the bladder, when it is pulled, can cause abortion, injury, and cause damage to the urethra with resultant severe bleeding and pain to the patient. So it's something you shouldn't do at all. Not under any circumstance should you try that method. People have also attempted to hyperinflate, and I've done it before. I've heard other colleagues to try it, to hyperinflate the balloon with increasing quantities of normal saline until it reaches its maximum tension or capacity, and then it will rupture in the urinary bladder. If the bladder volume is adequate enough, if you are not dealing with a contracted bladder, then of course this is a viable option. And so you can add normal saline through the valve and continue to hyperinflate the balloon, which is within the urinary bladder, so that it reaches a certain threshold, and then it can then rupture. You can actually hear the sound when it ruptures. Then you can then gently remove it without any further complication. I've done it a few times, but the reason why I'm not too comfortable with that is because sometimes you might the valve itself probably might be damaged after the attending physician or the nurse has forcefully pushed the syringe into the valve to try and deflate. There is this white hard plastic component of the valve, which if you attempt to if you force it downwards, can cause damage. And so the valve mechanism probably will not even be available for you to hyperinflate. So that hyperinflation technique might not even work. What I've tried that I would recommend is that you can use ultrasound guided approach via the suprapubic region. So it's a trans-abdominal approach, ultrasound guided, and then percutaneously advance a needle a 21 gauge needle or a spinal needle or any length of needle that can traverse the anterior abdominal wall, get into the urinary bladder, and then we burst the balloon directly under ultrasound guidance. And that I've done several times with success. So that's what I want to speak to today. So this ultrasound guided percutaneous rupture of the urinary bladder component of the catheter or the balloon is has quite a high success rate, and it's been successful and in the few times that I've been called to deal with this condition. So what you do is explain what you're about doing to the patients, and then do a quick bedside ultrasound to confirm the intravesical location of the urinary of the balloon. It's advisable that if the capacity of the balloon has been reduced by a previous attempt, you add a few mils, let's say 20 mils, through the valve so that the balloon becomes more visible within the urinary bladder. Then it's also an advantage to have the bladder filled with normal saline, or you clamp the drainage port and allow urine to accumulate adequately. But usually it's fairly straightforward to connect. You remove the hard plastic part of the given set, then connect the rubber components, and then instill normal saline by gravity. This will adequately fill the urinary bladder. Of course, it will cause some pain, discomfort to the patient, but with a little reassurance, usually this can be tolerated. So if you add just a little, maybe 100, 200 mils, that should be enough for you to properly visualize the balloon within the urinary bladder. Because if the bladder is empty, there's no urine, it will be difficult to perform this technique that I'm talking about. So urine in the bladder is an advantage for proper visualization and localization of the balloon. Then you clean the suprapubic region with antiseptic solution, and then infiltrate the skin, subcutaneous tissue down to the anterior bladder wall. This will provide some form of anesthesia. You can use xylocaine 1% as a numbing agent, and that will give the patient some comfort and cooperation when you are advancing the needle. Then, under ultrasound guidance, whether in plane or out of plane, usually I like to do it in plane, in transverse section, I advance a 21 gauge needle, but if you think advancing the 21 gauge needle might not get to the balloon, another possibility is to use the 21 gauge needle as an introducer, okay, and then thread a spinal needle which is longer through the 21 gauge needle, and then under ultrasound guidance gradually go through the anesthetized skin, through the anterior abdominal wall, so skin, subcutaneous, the rectus abdominis, in between the rectus abdominis, okay, then into the anterior wall of the bladder, go into the intravesical space, then under direct vision advance the needle so you hit the balloon, and this will help to deflate it. So when you hit the balloon with the needle, you will hear a pop sound, and then after that you can gradually remove the retained catheter, and if you need to maybe pass a new one for whatever reason, or patient does not have any further use for the catheter, then the patient can be discharged home. And that's, colleagues, is how you can use ultrasound to percutaneously deflate a retained bladder catheter. Hope you enjoyed this video.